So good morning, and thank all of you for taking time out of your incredibly busy days to join us. So we have two different groups that have joined us this morning, one in person and then one virtually. And we are very excited with the program that we're going to be putting on for you this morning. And I think you're going to really appreciate the effort we went into in finding the keynote speakers and then the panelists for this morning. So the name of the present or fall event is Game Changer, BHCG's work Wisconsin solution, the template for fixing U.S. healthcare. That's interesting. So the Commonwealth Fund, how many of you are familiar with the Commonwealth? Sorry. One of the, and Dave will go into a lot more detail on this, but we put a great deal of effort this year into obtaining funding for the study. And we actually have, and there's a press release that you can go to our website and see, but we have a co-sponsor, and that co-sponsor, and it's a brand new co-sponsor, and that's Gates Ventures. We have a co-sponsor in Baird, Lisa Stan. And then, Brian, where are you? Brian Marcella? Yep, right back. And so thank you for our co-sponsors. And then the continuing co-sponsors for the third iteration of the study include BHCG and Centivo. So the Commonwealth Fund report shows that more than 100 million Americans, 41% of adults, are mirrored in medical debt. So obviously the status quo is not working. More than 26 million Americans remain uninsured. And because of the latest changes in determining eligibility, that number has gone up dramatically. And then 1 in every 4 working adults in this country are uninsured, completely uninsured. So, for those of you that have attended prior events, you know that I usually point out what the operating profits, net income are for health systems that, or not health systems, but insurers that are operating in the state of Wisconsin. So United Healthcare, and this should be very disturbing to everyone sitting in this room. Their net income at the end of 2023 was $1.24 billion. $1.24 billion. The next closest was Anthem at 148. And then we go down to the regional carriers. So Dean, 16 million, Network Health, 25.3 million, Security Health Plan, 11 million. But what I'd like to go back to is this slide. So that $1.24 billion, where's all that money coming from and where's it going? Obviously, the money is going up to Minneapolis, right? And then it's coming out of the pockets of all of the stakeholders, and many of those stakeholders are represented in this room. So health systems, provider groups, employers, employees, and dependents. And when we look at this, this points out the need for change, right? If you look at the heading of the event this morning, it talked about change. We need to reduce market share for UHC. And who can we do that with? If you work collaboratively with Centivo, we can start to move that forward. And it's important that we do that because it's not only the dollars, but it's also the model that Centivo has in place with the high performance primary care centric model. So here, let me ask you this. Anybody in the room think that 1.24 billion in net income for United Healthcare is acceptable? Not a soul. We need to do, we need to start to work on that. So I'd like to thank our educational sponsor, Joe Blatz. Joe, Novo Nordisk. Thank you very much, Joe. Okay, agenda keynote presentation. Cora Upsell, Director, 322B Health Plan out of the East. And then we'll have a second keynote presentation with Ashok, the CEO of Centivo, and then a panel discussion supporting positive change in healthcare. And that's going to be with Cora and Ashok, and also with Pam Hannon from GE. Pam. And then we'll have a second panel discussion, and that's with represents the third iteration of the study. So you're going to get an advanced look at the third iteration of the study. And we are incredibly excited about this third iteration of the study. So it's Dr. Earl Steinberg, who is the lead researcher on the study. It's Dr. Wayne Jenkins, who's the CMO, is going to join the panel from Centivo. And then Dana Richardson, who is the CEO of WEO. And without Dana's data, we would never be able to accomplish what we've been able to accomplish. And then Mark Zistris is here somewhere, and Mark assisted Dana in moving forward and getting this database over to Aisha. So thank you. So Cora, with that introduction, please.
All right. Good morning, everyone. I'm going to start by giving Dave a hard time because my name is spelled wrong. And I felt like that was a good way to start it. So my last name is always spelled this wrong, but I was just going to say, so if you're looking me up, it's O-P-S-A-H-L instead of O-P-S-H-A-L. Mostly just because I wanted to give Dave a hard time to start this morning. So good morning, everyone. As Jeffrey said, my name is Cora Upsall, and I'm the director of the 32BJ Health Fund. And I'm going to tell you a little bit about us. But I want to start real quickly and say, I really am honored to be here today, and I'm excited about the title of this keynote. I have spoken in a variety of places, and I love purchasing coalitions because I believe it is a true way that change is driving in local and regional communities. And I thought that was such a neat way of thinking about what to talk about today. Usually I talk about data, and I love data. I laugh because my son is a master's degree in astrophysics and understands data. And I said, but I'm a data expert. He asks me data questions. And I was like, no, I don't know how to do data. I know how to talk about data. But today I get to talk about what it takes to drive change. So before I do that, I want to tell you a little bit of why I'm here. Like, okay, you're like, great, this woman from New York comes to Milwaukee, Wisconsin. What do I know about the Midwest? True, but I did grow up in Minnesota and I went to school in Wisconsin, and I am like deeply Midwestern to the core. I know how to be Minnesota nice, but over the last 5 years in New York, I've learned how to be a little bit of a New York edge. And that's part of the reason that I'm here today. So the 32BJ Health Fund, we are a self-insured multi-employer benefit fund, and we provide benefits to over 200,000 covered lives in the New York City area, plus up and down the Eastern Seaboard, Pennsylvania, Massachusetts, Connecticut, the DC area, all the way down to Florida, but mostly we're in the New York City, New Jersey area. We are a benefit fund, a Taft-Hartley benefit fund, which means we provide benefits to the 32BJ SEIU union. And these are your folks, if you've ever visited New York, these are your commercial and residential real estate workers, the doormen, the porters, your maintenance workers, but they're also school workers and security workers. And if you ever go to New York and fly into any of the area airports, these are your wheelchair pushers and your plane cleaners. It's a growing union, but it is, truly blue collar work. As a Taft-Hartley benefit fund, we are jointly governed by a board of trustees that's 50% the union and 50% the employers. And this is important because that means I'm responsible to the money and to the member. We have really high quality benefits with 100 premiums are 100% paid for by the employers. So there's no member premium responsibility. We have no in-network deductible, and we have low in-network copays. And we do that because we believe it is the responsibility of the health fund to solve the cost crisis of healthcare, but not on the backs of our members. And so that's why I'm here today. So let's talk a little bit about, I know I said I wasn't going to talk about data, but I'm actually going to start with a little bit of numbers because I feel like numbers really bring home the truth of what is going on in healthcare. In 2023, we spent $1.4 billion in healthcare. $1.4 billion. Inpatient and outpatient hospital costs make up 55% of our health fund spend. So you'll hear, and I read it today. I just read a story about it today. We talk about pharmacy, super important, but that only, it's maybe 25% of our spend. We talk about premiums, super important, but the reality is hospital prices are what is driving our costs today. The national average is about 44%, and for us, we're at 55%, and Wisconsin is the 5th highest state on hospital prices. So my guess is your numbers are probably similar. Healthcare costs make up a total of 37% of total compensation for our members. And in the past 10 years, wages have gone up 54%, but healthcare has gone up a whopping 230%. Which goes to show you that if a dollar is a dollar, right? And the more that healthcare takes up, that leaves less money for wages and other benefits. And you, everyone in the room and virtually, you know that. You live and breathe that every day. But this is why healthcare and talking about healthcare change is so important. So today I'm going to talk about 5 things that it takes to drive change in healthcare. Data, because again, I can't start and end with data. Benefit programs, tools you can be using, policy, and finally, courage. But let's start with the numbers. I'm only going to do this really quickly and briefly because I just said this on the other slide, but I think it's so important. How are you spending your money? If you get your data and you don't know how you're spending it, you can't fix it. I always say, I love transparency and I love the federal initiatives for transparency because you can't fix what you can't see. And that's why data is what drives our decisions and should be what drives all of your decisions as well. As you hear later today, you're going to hear from Ashok, who I know talks about data. You're going to talk about the Physician Value Index, also based on data. We talked about Dana and her all-payer claims database. All of this is just data. Because the reality is healthcare can sometimes be such an emotional decision-making process that as benefit leaders, we need to step back and ensure that we're thinking about that in the most logical way. So here's why you should care about your data. I'm hoping that everyone in the room is like, well, yeah, duh, Cora, we know data is important. But I always like to show the first graph, and then I like to talk a little bit about what you can do with your data. You can do a wide variety of analyses. You can create meaningful visuals. I have no doubt that multiple people in this room have had to walk into rooms and explain about their health benefits. And it's hard, right? Like, I'm not pretending it's not hard. I have brilliant data analysts who tell me on a regular basis how to do this and do this better. You can investigate different business questions. You can proactively engage with your data to provide your business leaders with key insights. I also look at this as the trust but verify. I'm not going to lie, I'm more on the camp of distrust and verify, but this is what you can use your data for. How many of you have been sold point solutions because you're going to save money if you just implement insert point solution here? Sometimes it's true, but when you have your own claims data or access to an all payers claims database or organizations like this, you have the ability to really validate the truth behind that. Which goes back to then my next point. So we talked about data. The next point is that you should drive benefit decisions in a thoughtful and analytical manner. So how do you create change? You get your data, but in the end, our job is about providing benefits to our members, right? That's our jobs. And so what you want to do is once you have the data, the next thing to create change is the concept of creating win-win cost containment solutions. I break them into two different categories. You have your utilization programs, and then you have your price solutions. Sounds really kind of, boring. But the reason I break this up is because everything we do in healthcare can go into one of those two categories, and they have different impacts. So I'm going to tell you a little bit how we look at these two programs. So let's start with our utilization programs on the left. We have no premium sharing. We have no in-network deductibles. We have innovative programs. We have a maternity program that's based on a high-value network that we created based on quality, where moms can go have a baby for $0 or no more than their first prenatal copay, which is no more than $40. All of the parents in here, did you have a baby for $40? But by the way, the only way we can do that is through all of the rest of the work that we do. I wish it included college, but no, unfortunately it does not. Though if you're interested in organizations that have funded college for their employees and for their employees' children's, look up Rosen Hotels in Florida. They made innovative benefit changes and design decisions that saved them so much money, they were able to give back to the community and send their employees' children to college for free. That's a big pot of money that's just sitting there waiting. Then we also have centers of excellence. We do joint and bariatric. Next year, we're going to be going into spine and some additional voluntary programs. And again, these are programs that drive members to high quality providers at a lower cost. So it is all about the utilization of the benefit. On the flip side, we talk about price solutions. And this is where I get kind of geeky and excited. So we've got pharmacy group purchasing. We're in a, I also would like to caveat right now on everything I'm going to say is with an asterisk of we will probably be changing some of these things. One of the things I want to just actually, that reminds me, I want to pause for a moment. I think it's hard when keynotes come up and tell you about these big grandiose things that you should be doing. I right now have Optum as my PBM in a spread deal. I am not saying that that is the most ideal situation, but it was when we made that decision 5 years ago. And so I only say that is that you got it. I'm not saying do everything at once. I'm saying like just do a little thing and then a little thing and a little thing. So if you're sitting here listening to me going, God, I can't do what you're doing, Cora. We didn't do it all overnight. And I have a laundry list of things we still need to do. But back to what we have done. We have pharmacy group purchasing. We're a member of Health Trust. We have saved boatloads of money up until this past year in our pharmacy benefit. It was incredibly a great move for us. But now the data, back to data, the data is trending where we're spending more money, and it's time to make a different decision. We've done massive amounts of data and price comparison of procedures by hospital, data comparison by procedure or hospital. If you look at this graphic, it shows you that a colonoscopy in New York City, and this data is even a little bit outdated, at New York Presbyterian costs in this data about $12,000, but we're now at $13,000 based on the most recent public data for colonoscopy versus $3,500 elsewhere. Now, I don't know about you, and I, again, not a clinician, not a lawyer, not a data scientist, but a colonoscopy is a colonoscopy is a colonoscopy. So why should one cost more than 3 times more by just going to the one with the name brand on the door? It's not generic medicine. It is not, it is just healthcare, right? It's just healthcare. And we did this, and the reason we've done this is that we wanted to understand where our members were spending money. Because as a self-funded plan, our members have really low copays, which really means where are we spending money? And then that leads us to network management. And the folks in this room, you all are acutely familiar with network management. That's why we have Centivo here. That's why you have solutions like Centivo. Unfortunately, the New York market is not as conducive for solutions like you all have here. We have had to make some really hard choices. We have had to tier our network. We have had to, and then we removed a hospital system from our network in New York City in 2022. But I want to stop a little bit and say, when you make hard decisions, you get outcomes that work. In 2022, when we removed a hospital system, we saved $30 million on 1.5 billion, but 30 million is a lot. So I'm now creeping up to close to $100 million in savings, but that number has gone back into the membership. In the most recent contract negotiations between the union and the employers, the union members got a one-time bonus, the largest wage increases in history, a pension increase, and the employers' premiums for the next 4 years are going to be increased at less than 3%. And we did that because we took the money we saved, because we made hard decisions, and we funneled it back into the benefit. So data, benefit decisions. I want to talk about tools. This seems like, again, sort of nerdy. I realized as I was thinking about my talk today and last few days, and then this morning, as I was like, it's kind of a nerdy talk. Sometimes I like to be more energetic, and I'm still energetic. I hope you all are not, bored yet. But I want to talk about tools, because tools are the things that we all need to do our job, because you don't all have 20 people working on an analytics team. And so there are some amazing tools out there that will help you understand how you're spending your money. One of them we have is that the 32BJ Health Fund and the Labor Industry Cooperation Fund, which is a partnership that the union and the employers made to fund and fight hospital prices, was to create this healthcare savings calculator. This tool we launched 2 weeks ago, and it allows you to put in how many lives you have and how much money you're spending on healthcare by state, and it will tell you how much money you can save as percentages of Medicare. I highly recommend that you go and look into this. It's a really baseline, gives you a sense to know, how am I spending my money? And it leverages tools like RAND, the RAND study, which talks about how Wisconsin is the fifth most expensive state. That comes from RAND. It uses the NASHB tool, which will give you cost break even based on how much their Medicare cost reports show. It uses the SAGE tool. And I'm saying all of these names, and I'm not expecting you to follow them, but my point is there are a lot of things. And now you all also have the Physician Quality Index. There is so much out there as employers that we have access to that is putting us in a position of power that we've never been in before. So I want to talk about power for a second, and that is where we ended up with healthcare administrator contract first template. Going to RFP is hard. It is so hard. And usually we go to RFP and the salespeople come in and they promise you the world. And then you start to go through implementation and you hear, oh, I'm sorry. I know the salespeople said we could do that. It turns out we can't. Operationally, we can't do it, or legally, we can't do it because of proprietary contract terms between the health carrier and the hospital systems. And Ashok and his team will talk about, they are very aware of this process that we flipped on its head because they had to go through it not too long ago. We decided when we ran our most recent medical RFP is we didn't want to follow the same old script. So when we submitted our RFP out into the world, we also included our medical RFP contract, contract. I didn't want Anthem's. I didn't want United's. I didn't want Aetna's, because who writes the contract owns the contract and owns the power. So we created a contract that we put out in our RFP and we said, in order to participate, you have to redline this contract and return it when you return your RFP responses. But that's hard. Again, I'm going to go back to, but not everybody is 32BJ with 200,000 lives. So we wanted to share this with you. So I now have a template contract that we encourage you all to use in your next RFP. It will put the position of asking these carriers to redline, how are they going to support you? How are they going to share with you the information that they deem proprietary? How are you going to make sure that you're not already, by the way, in March of a contract that already started in January, signing a contract and now you're stuck? It puts you as the employer in a position of power because it's your benefit, not theirs. It doesn't belong to United. It doesn't belong to Anthem. It doesn't belong to Aetna. It doesn't belong to Cigna. It belongs to you. So I encourage you all, go out and use these tools to become better purchasers. So we've been talking about as purchasers, what does that mean? And I want to just kind of say one of the things that I have learned over the last few years is that benefit design alone won't fix the problems that we're facing in healthcare. Change is hard. And, I think one of the ways that we have to think about this is the intersection of benefits and policy. On benefits, you can change your network, partner with Centivo, find a network that drives you to the high value providers in a transparent and, way. You can do a better contracting because, by the way, partner with Centivo and you can have more transparent contracting too. But there is a piece of the things that you can't do just by benefit design alone. And that is where I would say every employer in this room and virtually, you need to get involved in policy. You need to care about at the federal and state level what is happening to your benefits and how do you leverage policy solutions to allow you to do the things you want to do in your benefits. Support legislation. We have supported legislation in New York that has increased transparency and access to better data. We are launching legislation in Albany, in New York this fall that is a site neutral legislation called the Fair Price Act. If any of you all have lives in New York and you would like to join our coalition, we would love to have you, because this is about not paying more because your doctor was purchased by a large system. Because if you can get a flu test at a doctor's office, you shouldn't be paying more than if you get your flu test at the outpatient clinic. But we have to do this because this is how we're spending our money. And then the last thing I want to just point out that I know does not work for everyone, But 32BJ unions love public campaigns. And the reality is right now, in the power dynamic we have in healthcare, you have to do something different. And so there have been public campaigns that have increased the scrutiny and awareness of high hospital prices and anti-competitive contracting terms that exist in today's healthcare marketplace. And this is why I say there is that intersection of benefits and policy, because we can't just do it if you end up in positions of power where other people have more power than we do. And it doesn't always work. I wish I could tell you it always works, but it doesn't always work. In April of this year, we had granted our medical RFP contract to Aetna. And when we did, one of the contingencies was the hospital we had removed from our network because they were extremely overpriced, had to stay out of network. We fought hard for the right to design the benefit in a way that we want to design the benefit. What happened is they turned around and they said to Aetna, for 32BJ to keep us out of network, they need to pay us $25 million. Obviously, we said no. And we are now renewed our contract with Anthem because they said yes. Because they said yes, New York Presbyterian can stay out of network. But I put this up here because I want to say that this is hard. And it doesn't always work, but you have to keep going, which leads to point 5. How do you create change? You have courage. You have to have the courage to do something different. You have to have the courage to put together a physician value network that calls out the truth. You have to have the courage to use the data of an all payers claim database in a way that maybe is not always comfortable for all of the payers in the room. Or sorry, carriers. Self-funded plans are the payers. They are not. You have to have the courage to be like Centivo and stand up to this traditional model and say, we want to do something different. But I also want to say it's not just courage, is it takes collective action. And I'm going to end with why I love being in front of purchasing coalitions, is because it's about collective action. We cannot do it alone. 32BJ cannot be the only one flying the flag of healthcare change in New York City. And you all can't be the only one, you can't be doing it alone. It is through collective action and organizations like BHCG and other regional and local purchasing coalitions that really is what is moving the needle. So I ask you, I'm just going to end there and just say one last thing, is that together we can do this. It is hard, but doable. And so I challenge you all to have the courage to make the change. Thank you. Questions? Are we doing questions? All right. All right, then it's my pleasure to introduce Ashok, who I'm hoping you all know. And it's an honor to be able to introduce him because I think he and Centivo are really showing how you can change the model of healthcare and be successful at it. With that, Ashok.
Reminds me of being 15. Wow. That was something, wasn't it? So, do I press here or do I? Yeah, but how do I forward? That arrow?
Yeah.
It's changing here.
Well, now, Jennifer? Yeah,
It's okay.
yeah.
The show
sure.
will go on.
Dave?
Great. Thank you. So I have a few slides. I probably won't go in order. I don't think I'm going to hit them all. I hope Cora's talk was as provocative as we were hoping it to be. And I think the theme that I'm going to call a bit of an audible to and spend a little time on, excuse me, is twofold. So the first is about the reminder of why we do what we do. And it's the people that we're responsible for. It's the people whose lives, whose health, whose security that we have in one form or another chosen to be stewards for. And when I look at those operating profit numbers that Jeff wrote, look, we are we are the greatest and richest country and civilization in the history of mankind, and capitalism's at the core of that. I don't think any of us begrudge any of our businesses in our community as the business healthcare group the idea of making a profit. But when those profits are literally at odds with people's ability to get basic health care, with people's ability to worry about if their kids can play youth sports, because if they get hurt, they can't afford the deductible on their plan. If they're concerned about taking the advice of their primary care doctor because they don't know how much the drug is going to cost when they show up at the drugstore, that's where the profit motive has gone too far. And I think what we all need to think about, whether it's the BHCG solution that we're proud to be a small part of powering, or other things in the market, is how do we bring profit with purpose? And how do we put purpose ahead of profit to make sure that our moral compass is focused on the why we do what we do? So as an organization trying to bring a coalition together, working with BHCG, working with providers in the community, working with employers, and thank you to the significant number of you here today, clients of ours, advisor partners of ours, provider partners of ours. There's no way we can do any of what we've been doing without all of you. But it starts with the purpose, and it starts with the stories of why we do what we do. This is a real story. This is an individual here in Wisconsin who put the plan to the test. Not a young invincible with $100 or less in claims. Someone who needed the plan, cared about the benefits when she took the job, loves her employer because of her benefits. And this is an individual who is like so many others, have benefited from the fact that we've been able to work together to bring a solution that puts providers in the center, puts primary care in the center, takes out the waste, and is focused on, as Cora said so eloquently, the idea of we need to purchase better to solve the affordability crisis, not simply take the lazy way out and shift our cost problems onto the backs of workers. And so I'm reminded of this because change is hard. And those of you who are clients of ours and partners of ours, know that the easy button is to keep a plan, keep a carrier that folks are familiar with. It's easier for a lot of reasons. It's easier because that's what people are used to. It's changing, and I'll tell you a couple stories in a second, but everyone's heard of Blue Cross. Everyone assumes it's the good insurance. How many employees understand the difference between fully insured and self-funded? How many employees understand who writes the rules on what's covered and not? The reality is they don't. And so the easier conversation is to say, great news, we're staying with what we're doing, and the costs are manageable. But the reality is those employees who use the system are aware of that hidden underbelly of the status quo. And the hidden underbelly is what I call the anxiety, the toxicity of being afraid of having a health plan that you can't afford to use. And that's, I think, what we're all working on here together, and we're so proud to do. And I raise that because each of us have also dealt with the situations that we don't like to deal with. Let's just put that on the table too, right? The situation where someone went to urgent care and they didn't know, who Sentivo was. The situation where there was confusion about how things should work. It's part of the change management process. But while we're committed to constantly doing things better, while we're committed to learning from those situations, while we're committed, and our provider partners critically are committed to working through those situations, we have to always remember what the alternative is. And we cannot go back to a place where we are simply taking that easy button, which is to finance rising costs on people's backs. We can't do that. So let's remember that and let's remember the impact that we're having on people's lives. I was thinking back to 3 years ago at this time. There were zero clients. There were zero members. There were provider partners who courageously, to use Cora's term, said, we will step up and be part of this purchasing coalition. We will be at the vanguard of what BHCG is trying to do. And we will do that knowing that we will get some blowback from large payers. So a huge vote of thanks to those provider partners and a growing list that have supported this initiative and have worked to embrace quality and have had tough conversations inside their own staff and inside their own practices around what it means to steer to quality. And of course, a huge vote of confidence to the courage of the brokers and the consultants and the employers who have had to answer the questions and continue to answer the questions of why are we changing? What's in it for me? How is this going to be better? And a token of appreciation for all that we've gone through and the learning that we've had. But to think 3 years later, and interesting on the afternoon of a Brewer playoff game to think that Josh Hader was still the closer here 3 years ago. But 3 years later, I'm waiting for Matt to tell me that we have employer number 50. So hopefully we'll get to that half-century mark shortly. 30,000 members and growing as we grow in enrollment with new clients, with existing clients, a growing provider network. And again, what I'm most proud of is that story that you saw of that member, that patient, that person here in Wisconsin could work for any of these companies. Doesn't matter if you're in financial services, automotive, retail, a bakery. Across industries, people are the same. They want the same things. They want predictability, they want simplicity, and they want a plan that's going to be there in their time of need. With all of your support, we've been able to put that together. From a results perspective, we've shared numbers before, we'll share them again. At a high level, the results are both remarkable and, if I may, my team is going to hate me for this, utterly unremarkable. These are remarkable and unremarkable results at the same time. Why? So 2023, this has now matured. The actuaries tell me completion factors have been applied. These are good to share. 18% lower total cost of care compared to what the firm Milliman would describe as their benchmark for the market, for the commercial market. So a material total cost of care savings. That includes medical, that includes pharmacy. That's remarkable, right? If you could take 20 cents out of every dollar in what you spend to healthcare, you can reinvest that into your workforce. That is remarkable. Why is it unremarkable? It's completely unremarkable because it is literally the arithmetic straight line from the actions that you have bought into in developing the program here at the coalition. It is the arithmetic straight line of working closely with providers. It is the arithmetic straight line of working with Dana and the team around data, and Earl and the team around the data, and steering to quality, both in terms of primary care and specialist care. It's the arithmetic straight line of convincing providers that a program that is built for the employer, of the employer, and by the employer is in their best interest, and therefore negotiating strong competitive unit price, and also working with these providers to solve their own issues as it relates to prior authorization, removing the hassle factors of creating barriers to care, removing the collection of bad debt that has to be chased in high deductible plans. When those structural problems are addressed, and Cora nailed it, at the end of the day, who knew healthcare was complicated? But it ain't that complicated. It's about price and utilization. And these results in aggregate show the power of math. Now, does that mean for any given client in any given situation that they're going to save 18%? No. And so one of the things that many of you are strong consulting partners who've worked with BHCG and who've embraced the program have understood is that healthcare fluctuates. You might have a great year out of the gate and be feeling really good, and year two might have some bumps. Might be the opposite. Your first year might be a little bumpy. If you're a smaller group, you might be subject to a little more volatility. But what you get with us in all of those situations is the commitment, as Cora's described and as Jeff's described, to absolute transparency and an accountability that we don't profit one penny if your costs are more than you want them to be. We are organized in everything that we do economically to bring your costs down, and that's a commitment that we will forever have here with BHCG. The last point I'll make, and again, credit to the provider partners, the practices, the primary care teams in the community. What we have helped do together is remind employees, remind families of the importance of primary care. It became easy for us to offer folks a big phone book and say, go wherever you want. But the reality is primary care matters. The GNS study proved it. The physician value study has proved it. Primary care matters. And so courageously, employers have gone to their workforces, as many of you have done, and said, I realize that it may feel like it's a little more work to start your experience with primary care, but it's good. Work with us on this. What our partners have done from a primary care perspective is now they have the freedom to practice at the top of their license, not having to collect cost sharing by making primary care free, not having to worry about whether a family will adhere to their treatment plan because of cost concerns, not having to worry about whether procedures or tests might be arbitrarily held up in red tape because it's something that was designed in a faraway land for the benefit of an insurance carrier. Those have led to the last three numbers here, which, as Dave will talk about, I'm sure, on the panel, how do you move dollars out of bad care and into good care? Primary care, good. ER, not so good. Hospital, even less so. And hopefully I'm not offending anyone who runs an ER P&L, but we want to keep seeing that number go down. So I'm going to close on one last point. And Peter and the team at O&H have just been fantastic, kind of going into, again, our third year with that group. I'll let you read the numbers. I'm not going to do that here. But the thing that gives me the most pride about this example, and now so many others, is this is an organization that, by mitigating cost, by shifting, transferring wealth away from insurance companies back to their workers, they've seen a year-over-year increase in enrollment in their plan. What does that do? It means they have workers who are more productive. It means workers who feel more secure. It means folks who are extraordinarily loyal. And oh, by the way, for you healthcare technical nerds, it means a more stable risk pool, because the folks who are participating now who weren't participating before probably were rolling the dice because they assumed that they'd win that bet. It's a win-win. It's a win-win for everybody when it works. And the courage that Cora referenced, the staying power of the fact that what's new and what's disruptive is the right thing to do, as long as one thing is kept in mind, and that we're focused on the family. And if we focus on the family, great things can continue to happen. Thank you.
Based on a more soft. So Antigua has provided savings 1 point, and the number of those states holds that never that corporate consulting at BHCG, and I'm being very frank, BHCG and Evo, that is, and it's a huge problem for the taxpayer, because these savings not even taxed out. Any comment?
Well, one last word. You mentioned I gave a number of example employers and industries we work with. We've had, and they're in the room here, some terrific partnership in education, both private and particularly in this market in public. I have to say, it makes me feel great, right? It makes me feel great when we can take these sorts of programs, when the power of collaboration of the caregivers, the clinicians in your community, the purchasers in the community, the benefit advisors in the community, when we can bring that to bear on behalf of teachers, on behalf of folks who have sacrificed to take care of all of our children and to do all the things that we've done in that space. So appreciate, I know several of you are in the room. We're proud of the work and the fast growing work we're doing in the public education community here, and we look forward to do a lot more of that. So thank you.
Good morning. I'm Dave Olstorff. I'm the strategic consultant for the Business Healthcare Group. I've worked with the coalition for a long time. I'm also the chief actuary at Centivo, so Ashok will make fun of my numbers all the time, but it's an important role. We're going to have a little bit of a panel Q&A here and talk about sort of what everybody's heard and really focus sort of on the big picture question of, based on what's going on in Wisconsin, is it really a model that we should talk about exporting to the rest of the U.S.? And so, Ashok talked about some pretty important numbers and some pretty important impact on people's lives. I'm going to ask the first question to Cora just to get sort of an immediate reaction. So what did you think? What was intriguing? What did you want to know more about? What did you want to bring out to the East Coast, and what things gave you pause?
I think it's great. I mean, it's the short answer to that question, I think. And Ashok and I have talked, New York City is a really weird healthcare market. I came from the Midwest where everyone has primary care docs, and I moved to New York and everyone goes to see their specialist. And so it was odd for me. So I think finding a model that can bring the transparency employers are demanding with the care that actually will drive change is absolutely that like sweet spot that I think that Centivo has really nailed here in Wisconsin. And I'm hopeful we can eventually figure out how to fix the New York market in the process.
Pam and folks, Pam Hannon is the retirement healthcare leader at GE Healthcare, which is sort of an interesting organization in that it's a new company that's a really old company. Been around for years, but went out on its own relatively recently as a spinoff from GE. And so you've had to make a number of decisions about what the future of GE Healthcare looks like in terms of its benefit programs. Obviously you've heard the same thing, and all the rest of us did. Sort of what resonates with you as you look forward in the GE Healthcare space. You're a national employer with a big local population. How does this all sort of resonate with you?
Oh, great. Thanks, Dave. When I first heard about this program, I started to resist and said, no. I've seen POS, I've seen HMOs, not interested. And fortunately, Dave and Jeff had the patience to help teach me how this really was very different. And it was actually everything that I believed in for many years. And through being one of the first companies to implement one of the major navigators in 2014 at a prior company, feeling like employees need help to get through the system. The fact that you have the PCP at the center of that, who is no longer encumbered by rules, delays, frustration. I'm sure many years ago, you might have been in your doctor's office when he's trying to get something done and he and the nurse are rolling their eyes and looking at each other because they have to call XYZ insurance for an approval of something that's very necessary, and it frustrates you, it frustrates them. So I'm excited about the fact that our employees are now going to have that help in the system. They're not going to waste time. They're not going to be taking lots of time away and spending lots of money on things that are inappropriate. And they're going to have a higher quality network to help them. And, that leads to better employees. So we have a lot of work to do as a new company. We have a lot of expectations from Wall Street, and we need our people focused on them, on getting in the office and getting things done, not on trying to figure out healthcare.
Let me actually follow up a little bit on that, Pam, because you've got an interesting place sort of in the business world where you're in a healthcare manufacturing and production kind of world, using technology to help make healthcare better. That's got to create some interesting challenges between how you run your benefit program and what your business is really intended to do. How does that factor in?
Yes, absolutely. We sell MRIs, X-rays, mammogram equipment, incubators to hospitals and health systems and emergency rooms. And so we have to be, careful that we are not, coming out and saying the healthcare system is bad, because we are part of the healthcare system ourselves. We're trying to just do exactly what Centivo is doing, which is improve the health of our employees and really of the world. So that's really our focus. So I see us tied together with them in moving it forward. It does make me the number one contact person for all of our sales employees, who I have to remind I have a fiduciary duty to provide appropriate spend and appropriate healthcare. So I just can't add every single option and every single radiology center and every single mammography center into our health plans. But it does actually tie in pretty nicely that we are part of the system. We feel we're trying to advance healthcare and partnering with Centivo. It was honestly one of the few times in my career where, as we talked about a new innovative approach, the senior suite heads were nodding like, yes, we all know we need something better. And we know what we have today isn't working.
So Ashok, let me stay on that whole balancing business realities with sort of day-to-day concerns. You know, Centivo as a health plan obviously has a very important emphasis on working collaboratively with its health system partners. But BHCG brought Centivo to this market to create a meaningful amount of change and to sometimes ask the health systems to do some hard things. What's your sense? Have we struck the right balance? Have we been able to sort of thread that needle in terms of collaboration that also drives positive change?
Thanks for the layup, Dave. Is my mic on?
Be a little bit.
I'm gonna try the on button.
Yeah.
Is that better? Okay, good. I'm a quick learner. So look, I think, Dave, it's a good question, and it's a continuous work in progress. I don't think we should admit to any type of utopia for two reasons. So I think at a strategic level, you have a number of hospitals and health systems who are equally frustrated by the status quo. And then you have a number of other hospitals and health systems who are deeply profiting from the status quo. And Cora's chart said it all in the New York market, and you've seen the data in the Wisconsin market, and Rand and others are publishing similar data in other markets, and it tells the same story, that in effect, employers are massively subsidizing the operating margins of American hospitals, and that is a reality. Some senior leaders understand that, and I think have embraced the idea of we need to start to be the type of change that we want to see in the world, to channel Gandhi, and the fact that it's with a smaller, more disruptive set of stakeholders like Centivo with BHCG, as opposed to if they were to change all of their revenue in one fell swoop. They tend to get behind that, and those discussions tend to go well. From a day-to-day execution perspective, though, and this is what affects many of you and your employees and their families, the entire system is built on open access PPO, with provider groups having internal incentives and internal processes to maximize how much money they're getting out of purchasers. It's not evil. It's back to the capitalism part of what we talked about. So some of the yin and the yang is, how do you get, so first you have to find the partners who are strategically aligned. I think we've been generally very successful with that in Wisconsin. The next part is, how do you get that strategic vision translated to the day-to-day? I gave the example earlier. It's a real example. I'm not going to run from it. I'm not proud of it. But when someone at a front desk rejects a patient because they don't understand what's on the card or the insurance, that has nothing to do with anything except one thing: money, and a concern about whether they might get paid. The minute we embrace that and understand that so much of how things have been built on the provider side have to do with revenue cycle, have to do with collections, have to do with managing their own businesses in a world of skyrocketing high deductibles, the quicker we can help take that next step to make the operations match the strategy.
In a second, I'm going to ask for any kind of questions from the audience. And I think for those of you who are online, I think you can put it into the chat function. Hopefully we'll pick it up there. I'm going to ask Pam a quick question first. Pam, you've had some historical experience working with other employer coalitions and looking at ways to really amplify the voice of individual employers by collaborative action. Sort of how do you rank what BHCG is doing relative to what else you've seen?
I was at Chicagoan, for a long time. And so when I started working in the Wisconsin area, in Chicago, we knew we had Wisconsin employees and healthcare was expensive. And I didn't realize the power of BHCG until I somehow randomly got connected to Jeff several years ago. When I look at the room, I can tell you that when the purchasers come together, you can really make change, whether it's through the purchasing coalition, through user groups to go back to the providers and say, no. Don't tell me that you are going to make me do this because I know you don't do it for someone else. Or bringing that voice together can really push change. So I think it's really vital. Just looking at the group, every time I come to a meeting here, there are more and more people involved. There's more and more people on the phone. And so getting the word out is really important. So I don't know how we make sure other employers see it, but I think I was counting on your slide. You didn't have my logo up there, so I think I'm number 50.
We want to be sensitive about whether your team has heard about it yet.
So I do think it's really essential, and other coalitions are doing fantastic things. And if I had been involved with Midwest Business Group on Health out of Chicago for many years. I was the chair for the last 3 years. And just the number of activities that can be done in very small coalitions. Jeff, is a very, very large coalition. But seriously, the amount that the purchasing coalition can bring to you is invaluable. And I hate to say it, it's unbiased. And not that I love my consultants, but sometimes I have fantastic support from them, and other times I have to ask them, why are you trying to tell me about something? Because it seems like all the consultants are telling me about it, and that seems like maybe there might be some commission in there that I'm not comfortable with.
Are there questions from the folks in the audience? Go ahead.
All right.
And I'm
for-
quick
yeah.
repeat the question for those online. The question was, I'll kind of boil it down. For those of us who haven't done as much in the public policy space, what should we be thinking about and how do we interact with our legislature?
So that's a great question. And I am not sure what's happening in Wisconsin, but I'll speak a little bit at the federal level. So at the federal level, there is the transparency and coverage rule, which is the rule that says hospitals have to post their prices. There is the MRF files, which is the rule that insurance carriers have to post the prices for their payers, for their clients. Those rules are not being followed in a way that makes it actually usable. I joke that it's machine readable files, not people readable files. So there is legislation out there. It passed in the House. There is a Senate bill, which is the Braun-Sanders bill, related to increasing transparency, making the files actually usable, as well as increasing support for eliminating anti-competitive contracting terms. There is some site neutral legislation out there. It's for Medicare, but it's also how do you then apply that to commercial payers. There's some conversations happening at the federal level related to how do we take the Medicare drug pricing negotiations that happened and apply it to commercial payers. So again, we can benefit from the work that's being done at the federal level. So I think really the biggest push right now is on transparency. And it probably actually, as dysfunctional as the federal government sometimes is, it is it's a bipartisan support. And Senator Braun is going to be the next governor of Indiana. And he has been, a staunch supporter for transparency and increasing access to healthcare. And he's partnered with, Bernie Sanders on the opposite end of the spectrum. And so I think there is some thought that the lame duck Congress, when they come back, will pass some sort of transparency bill as part of the government funding. But I would say that's the biggest work that's happening that's related to commercial payers. Great.
Yeah.
It's very deceptive
same
over
color.
here. It is,
Yeah.
yes.
So I would add, in the state of Wisconsin, there is also some active work going on around price transparency. And I think Wisconsin Manufacturing and Commerce, if they've really led the way and are pushing a couple of different initiatives forward. So one is a strengthening of the federal hospital price transparency rules here in the state of Wisconsin. So that's one opportunity. The second is they're interested in a price transparency website that would allow health plans and employers to be able to access average prices at the provider level, in a way that you could utilize that information in your benefit plan designs, but also in negotiations with providers. So a lot of the price transparency websites that are coming up are consumer oriented, and that's a good thing. But you really, as a consumer, if you've ever used these sites, you kind of have to go organization to organization, and because they're only going to shop 2 or 3 organizations, right? This would actually allow a payer or an employer to, pull down a lot of different services from multiple different providers at the same time. So that's a second initiative that's going on in Wisconsin. Both of these, I think the primary sponsor of these is Mary Felskowski. So if any of you are in her district or know her, she would be the one that you might want to talk to, or you certainly could talk to Wisconsin Manufacturing Commerce. And then there is a third initiative out there that was started last year, and it's on PBM pricing. So those are kind of 3 big things in healthcare going on in price transparency. I do want to say that and make it clear, WIO is not the one pushing for these, because there's been some misunderstanding about that. So I think your best bet is to work through Wisconsin Manufacturing.
Thank you, Dana. And with a panel like this, I keep them up all day, but I do want to make sure we save some time for the other panels. So I'm going to have one quick final question for Cora. You noted the fact that 37% of your people's compensation is healthcare. Does that make it harder to take big risks, or does it make it more necessary to take big risks?
Absolutely necessary. We're all going to be left with a choice where there is no real choice left. When healthcare is 37% of our compensation, and just 10 years ago or 15 years ago, it was 17% of total compensation. So at some point you have no choice. And I laugh because it is really easy to, I think about healthcare as an antagonistic piece between members and the employer, or between you all as benefit leaders and your CFO on how are you going to be spending money. But at some point, the only way to do it is to fix it. And so I think the fact that healthcare continues to be a growing piece of everyone's budget, absolutely essential that you have to make a different choice.
I'd like to ask Pam and Cora a question. So we've said some things today that are almost as if they're point of fact. The idea of making primary care free, which we know you're doing it in the option. Pam with Centivo, you've had Cora free primary care at designated centers for several years. You have a no deductible plan, you have a no premium plan. What we see out of Wisconsin, with some notable exceptions, is very different. We see a large number of employers, especially in the small to medium space, with extremely high deductibles, saddeningly high deductibles. We see behavior from certain advisors, not those in this room, but we see behavior from certain advisors whose gut reaction is to manage cost by asking for options with even higher deductibles. What would you say to those employers and those advisors, given the strategies you're taking on, about the approach of using deductible and using increasing cost shifting to manage the quote unquote problem?
Cost shifting doesn't save healthcare. Cost shifting just means I mean, I think it's going to, I am sure there are probably studies. I do not know them, but I'm sure, and I'm sure if I say this, Ashok's going to know which there are some that show if people avoid care. I think there is something about like over 60% of people in this country have avoided care because they can't afford it, which means your employees are going to get sicker, which means they're going to miss work, which means that you're going to end up having short-term disability or long-term disability of your members. To me, I feel like it's confusing the fact, right? It's like, oh, I can't spend any more money. You're right. You can't spend any more money in the way you've been spending your money today. So I would say is that the answer is not to do, the answer is A, you're just going to end up, your members are just going to get sicker because they're going to avoid care. But B, then spend your money differently. You have all of those amazing facts, and I loved, Ashok, your component, your argument that, you're at 0, everyone's at 10. We made a big change. We were at negative 4.5%, and then we were at 0. And this year 3, we're now going to be somewhere between 8 and 9%. Because you have to make structural changes to make a difference, or it will even out. And Centivo and the work that I think that Pam, that you're doing, it's that structural change is the only way to make it really have that longevity effect.
Yeah, years ago when I would do employee meetings, I would always tell employees that the most expensive place you could go to is the emergency room, and therefore you could spend 10, 20 visits with your PCP and spend less than 1 visit to the emergency room. And so when I saw free PCP visits, I was like, right on, because I was only mad that I can't do it my HSA until after the deductible. And so if there was any wish I had, it would be that government would remove these restrictions on high deductible plans that only allow 1 preventive visit a year, let people get their preventive visits, get your diabetic visits, get your blood pressure checked, and not make the emergency room your primary care doctor. I mean, people have to go to the emergency room for emergencies, but some people go to the emergency room because they're looking at their deductible. The other thing that used to get me furious was the colonoscopy, remember? Get your free colonoscopy. Oh, the visit with your doctor beforehand or to talk about your results or the great stuff you get to drink, that's all extra. And by the way, we found a polyp, so now it's not preventive, it's $700.
Diagnostic now.
Now it's diagnostic. I in 1999, I told Aetna all colonoscopies are going to be free. And they said, people are going to abuse it. I said, really? You tell me who they are, because we don't want them to work here.
There's a run on prune juice.
Yeah, they're a little bit off if they find that that's something that they're going to abuse. But to get back to the whole idea of preventive care, I've always been pushing preventive care. The PCP visits will allow people to manage those chronic conditions, because if every time I go to the doctor, I have to pay $150 or $85 or whatever it is, I'm going to try to stretch it a little bit.
Mm-hmm.
And then that little situation becomes a big situation. And then the next thing you know, I'm fainting at my desk, or I'm not doing well, and my family member is taking me to the hospital, and I have this huge bill and this huge problem. So I think the PCP, I have evaluated claims for many years. PCP visits have never been my number 1 spend, never. Never. And I wish it would be. And I wish mental health would also be in there too. So, when you get, an ounce of prevention, you can really avoid then these situations becoming now the time the person goes to the doctor is when they're inpatient for 7 days and really, sometimes they don't make it back. So it's not a good thing.
So I'm gonna give Cora the last word, then we're gonna switch from this panel to our next panel. And I think I know what you're gonna say, Cora, but I'm gonna ask anyway. This all sounds awfully disruptive. Isn't that a problem?
This is my favorite question. It's only disruptive if it's working, and our current healthcare industrial complex is not working. So I would challenge everyone to rethink the concept of disruption. It is disruptive means today works. Today doesn't work. I would say what we're asking for is revolution. And, that is okay. And I think that if you explain to your employees that we are going to do something different because do you think it's working today? I bet most of them would say no. For the exact same things that Pam is saying. So I would challenge you all, don't think about how hard it is because it's disruptive. Think about the fact that we're trying to change and revolutionize healthcare.
Thank you. Quick thanks to our panel. And I will ask our, excuse me, ask our next panel to come on up.
Yeah, I can see that.
We are going to move to a second topic, which is the physician value study that Jeff talked about a bit earlier. The physician value study is really a signature effort of the Business Healthcare Group. So I'm going to invite my panelists to come on up here, and I'm going to have Lisa take over moderating. I'm going to give you some quick thoughts, but the panel, in front of you, you have three very distinguished individuals who have been really significant in the industry in looking at ways to measure and to manage physician performance. Pearl Steinberg, who is a physician who has had numerous roles, starting with connections to Johns Hopkins, working through a number of different other organizations, is currently an adjunct professor at Hopkins and a consultant to IASHA, which is sort of his connection into the physician value study. I'm joined by Dana Richardson, who you've fortunately already heard from a bit, who is the CEO of the Wisconsin Health Information Organization, Wisconsin's all-payer claims database, and Wayne Jenkins, who is a physician and is the chief medical officer at Centivo, who also has been in lead clinical roles at Vanderbilt Health and at Orlando Health, and so has lived on the provider side, and we'll get that perspective. The physician value study, for those of you who are less aware of what it is, think of it this way. When you take a very progressive and motivated coalition who wants to really look at ways to enhance value in the geography in which their people work and live, when you are able to access a very large, robust database that includes many millions of lives and many billions of dollars of healthcare spend, so that you actually do have the kind of valid data necessary for really big studies. When you have a organization, previously called GNS Healthcare, now called IASHA, which has one of the most advanced machine learning, artificial intelligence models out there that uses causal analysis to really look at what the opportunity is to drive change. When you then bring in a administrator who is going to help wrap those things together under the direction of the coalition, what do you get? You get the effort to put together what we describe as the physician value study. Physician value study is, from my perspective, as someone who's a really old actuary, probably one of the most advanced, most sophisticated analysis of physician performance at the individual physician level that I have ever seen. Something that really is I think, from a marketplace standpoint, both necessary and incredibly valuable, and can be used in incredibly useful ways. The study originated back in 2018, and we brought results forward in 2019, saying, let's look at some very specific things. Take a look at the data in WHEEL and look at all of the performance of the individual physicians in the state of Wisconsin who had enough data to be valid. A significant focus on the primary care physicians. Went through and looked at what the results look like. Did we in fact have dramatic variation between individuals? Spoiler alert, yes, we did. Was there an opportunity to really save substantial money if we took a look at how we could change the way physicians worked within the state? Again, the answer was yes. Came forward with the results, got some pushback from various areas. Some of especially the industry groups saying, we're not really very excited about, you telling us what's right and wrong. Obviously, your data is no good. That must be the real issue here. And didn't have as much engagement at the provider level as might have been an opportunity. Sort of plowed through that and said, we think it really is telling us some really important things. So we repeated the study 2 years later with a larger data set with some additional modifications to the process to address some of the concerns that people had in the first iteration. And I think this version 2.0 was an even better version of the study. We took advantage of some of the learnings we had and brought it forward and had some really key results that Earl's going to touch on. But one of the things that was interesting was a different level of marketplace acceptance, especially in the healthcare community. Had provider groups who started to look at this and said, okay, number one, it's a major employer group who's doing this and really supporting it, and it's not going away. So we can't just hold our breath and hope it stops. Maybe we should actually pay attention to what it is. And had a number of health systems that went out and said, let me get the data. Let me see what's actually out there. Let me look at it from my individual physicians and see what we can do. The other thing I give the Business Healthcare Group a huge amount of credit for is they said, this is a study that shouldn't be used to punish people. This is a study that should be used in a collaborative exercise to really improve healthcare all the way through. So as you hear from the speakers, you hear the conversation around what the physician value study is. If nothing else, remember it's that. It's a continuous improvement opportunity, something that uses data really effectively to show what happens when really strong performers work at their best. We came and said we need to do this as version 3.0. We need to repeat the study. And we need to, again, take advantage of some of the opportunities we had. We said there's certain questions we can answer. And the big ones really were, is the physician performance consistent over time? Simply put, is high performance sticky? Am I doing well in one period of time? Am I doing well in that next period of time? And we're going to get that comparison between the version 2.0 and 3.0 results. That's a really important thing. We're adding something new in version 3.0, data around the social determinants of health. One of the pushbacks has always been, well, the variation in physician performance is really due to SEOH measures. Well, we're going to look at that very directly. Now have the data to be able to do that. We have the analytical engine to be able to do it. That's really important. We're going to look at how much we can do to make these results even more actionable. And part of that is bringing in a physician group from the local health systems to say, here's what would help me as a physician leader to actually take these results and to make them more actionable. And we're also going to look at that bigger question of, can we take these results that are being done in Wisconsin and make it replicable across the country? It actually was one of the questions that was intriguing to Gates Ventures, obviously an organization that has a national, frankly, a global footprint. And it's saying, how do we take good ideas that are being done in local marketplaces and expand those? So one of the things that we are committed to do in version 3.0 is to actually publish the results in academic journals and other places that will spread the word. So that's what's going on in physician value study. I'm going to let the panel kind of give a quick thoughts as to what is actually in the PVS itself, starting with Dana talking about WHEEL's role, have Earl talk a little bit about methodology and practices, and then I'm going to let you hear from the panel sort of in a kind of open-ended dialogue. So Dana? Oh, and yes, I should introduce the moderator. Lisa Merzinski from Baird is going to moderate the panel discussion. Baird being one of the new co-sponsors of the study has a really important role to play. So thank you, Lisa.
Thank you, Dave. So I'm just going to spend a couple minutes today talking about some key features of um, the data that's being used for this study. I am the CEO of the Wisconsin Health Information Organization, and you can see that our mission is to create more data and better information to advance actions. So the WIO Board of Directors is very interested in the opportunities like this one, where we can have the data that we house and steward used to actually inform change within the state of Wisconsin. We are a public-private partnership, which means that we work with the state of Wisconsin, but we also work with private organizations. And under Chapter 153, which is a statute under which WIO was actually created, we do have an obligation to analyze and publicly report information on the cost, quality, and efficiency of healthcare in the state of Wisconsin. So we provide data and information to any organization that is interested in improving the healthcare delivery system in Wisconsin and the health outcomes of Wisconsinites. You can see in the box on the left-hand side, as of the end of last year, we have 5.36 million insured lives in our database. It represents $375 billion in healthcare charges, and we're coming up on 900 million claims. So this is big data in healthcare. The data includes commercial, self-funded, Medicaid, and Medicare Advantage data. And I'm going to talk a little bit more about a new database that we created called the Socioeconomic Data File, or we refer to it as SURF. But before I do that, I wanted to kind of think a little bit about why is the WIO data the right data for the physician value study? And there is a concept in reporting called fit for purpose, and that is you should always use the data that's the best fit for the objectives that you're trying to create, the questions you're trying to answer based on your study or report. So claims data has been in use by multiple organizations for over 30 years. The advantage of that is that there has been the opportunity to have public discussions about claims data. There's been the opportunity to do research and to learn from the results of those research studies what improvements need to be made in the data for it to be used for reporting purposes. Because if you think about it, claims data is really created for a bill, right? You go to your provider organization, they create a bill, that bill goes on to your health plan or your administrator in order for that bill to be paid. So the good news about that is that there is a standard structure for claims data. Every single data element has a structure, it has a definition. There's a lot of training that goes into that system so that, of course, the payment is correct, right? At some point, the provider organization and the payer agree that this is the right amount. So there's a lot of scrutiny that goes into claims data before it is used for reporting purposes that's advantageous in improving the accuracy of that data. We actually bring in data from 15 different organizations, the same claims data in a standard format. We take that information and we also apply multiple different quality assurance checks on it, both automated quality checks as well as human checks. So we have people that actually look at the data and say, are these data elements filled with the data elements we expect them to be filled with, right? Once we get that information, though, it's still in a claim format. So we have to reorganize it all. We have to reconcile it because sometimes somebody pays a claim and then later says, oh, no, that's not the right amount, right? So we have to pull that out. We have to put the new one in. We have to do all those types of reconciliations. And then we have to structure the data so that it can be used for analysis. We also create something kind of unique among the APCDs out there, and that's called the WIO ID. And what the WIO ID does is every time a claim comes in for Dana Richardson, it says, oh, there's Dana Richardson again. I'm going to put this number. The number doesn't mean anything. It's just an assigned number. I'm going to put that number on all of her claims. Or it says, I don't know Dana Richardson, so it gives me a number. And if it doesn't know, it kicks me out into a bucket and we handwork those. But this identification number allows the analyst to be able to track Dana Richardson over time in a de-identified way, right? They don't know that it's me, but you can track individuals, but more importantly, you can track populations and you can see changes over time. You can do before and after types of evaluations on the same population. So it's turned out to be a really critical advantage to have this ID system. And then we also host a provider registry. So we organize to the best of our knowledge, knowing that the minute we make updates, there's another change. We do keep track of what clinicians actually work with, what provider organizations, what provider organizations have been bought by this one. So in the end, the data can be reorganized and utilized at the provider, but also down to the physician level. And I think one of the challenges that many organizations are going to have, unless you're a super big like United, but a lot of the payers are really not able to drill down to the individual clinician level, the physician level in their data, because the data simply isn't big enough. You need a lot of data to do that. Because if you think about it, if you're measuring something at the state level, you've got this much data. You bring it down to the county, you're down here. You bring it down to an organization, you're down here. Now you want an individual clinician. And in order to have enough data for that, for those results to be valid, you have to have multiple events for that individual clinician. And so Earl's actually going to talk more about the business decisions that are actually made within the study that, I think were very thoughtfully and very conservatively made in a way that, we can feel relatively confident, never 100% confident, but relatively confident that the results actually reflect the care that was provided. The last thing I'm going to talk about is something called derived data elements. And I guess I actually missed one on this slide, Earl. But in addition to the claims data, we actually create data, which are called derived data elements. And we do this for actually 4 different elements for the physician value study, for other products that we have as well. One is called an episode treatment group. The episode treatment group, normalized pricing, and a third one I didn't put on this slide called evidence-based measures. We actually license the Optum Insights groupers to do this work. They are the gold standard in the industry for this work, at least today. And have been developing these groupers for over 20 years. So an episode is basically all the care that is related to a certain concept. So if you're having a surgical procedure, it would include any pre-surgery care that you receive, your surgery event, and then any post-surgery care. And that would create a surgical episode. If you are looking at chronic conditions, which is often common in this study, it would take a target date with the first diagnosis of that condition, and then it's 12 months, but only the services that are related to that condition. So by using these indicators, there's over 10,000 episodes in the system. It allows you to be pretty confident that what you're putting into an episode is actually the care that was provided with that episode. The evidence-based measures are similarly done in that there are over 800 evidence-based measures, and these are typical quality measures. You've all heard about them. Did you get an aspirin within 2 hours, et cetera, et cetera. But they are different quality measures that can be applied to claims data because some quality measures require additional data, right? They require lab values and things like that, which we do not currently house. So we offer those. And then the third is a concept called normalized pricing. Normalized pricing is a little tricky, but it basically applies a standard dollar amount to the same service, regardless of who provides the service. So it's not using our cost information. So if you have an x-ray of the left thumb, that x-ray of the left thumb is going to cost the same regardless of what provider provided it. That information is actually derived from a very, very big database that Optum houses. It includes their paid amounts, but also the paid amounts of hundreds of health plans in the US, as well as Medicare data. They find the average price, and then they adjust it for geographic regions. So things like, what are the labor costs in Wisconsin? What is healthcare inflation in Wisconsin? Adjustments. So this isn't the exact price that anybody paid, but it is a very good representation of an average. Why do you want that? Because if you standardize the price and now you look at an episode, you can see if the episode actually had more units of service, because more units of service means more services were provided to create the same output. And that's where it becomes very actionable for providers to be able to look at their own information and say, oh, why do we do more x-rays? Or why are our pharmaceutical costs higher than other provider organizations? What can we do about that? So those are three grouper elements that we add to the data. And finally, for the first time, I think Dave mentioned, we do have a socioeconomic reference file that we have created using a research concept. So we took the 5 million people in our database. We had them geocoded down to the census block level. So that means the people in a city block, right? We took that census block information and we applied to each person in the database data elements from the American Community Survey, which will go to the census block. It's a federal survey that's validated and updated on a periodic level. And then we also applied something called the Area Deprivation Index, which is an index of 4 commonly thought of as social determinants of health, which were income, education, employment, and housing quality. So this index was designed by the UW-Madison School of Medicine and Public Health. The information's available on their website. But by applying these data elements at the individual person level, granted, it's not them reporting it, but it's the characteristics of the people in the census block they live in. Now you take that WEOID, because this is all de-identified, and you add that to the other data. And now you can look at the influence of social determinants of health at a population level. So hopefully that all makes sense. Dr. Steinberg.
Thank you. I want to start by saying that although I oversee the analysis of the data, all of these physician value studies have really been a team effort between Jeff, Dave, Dana, and myself, where we have interacted regularly, made joint decisions about what we think the right business decision is in a particular area. And I also want to acknowledge several other people who are the data analysts on behalf of Aisha, who actually crunch the data for me. I'm a quality fanatic. And so we do a lot of QA on the data. And in several instances, we've had to go back to Optum because we've identified an issue that doesn't make any sense, et cetera. And WEO has been extremely supportive in getting those things done. The next thing that I want to do before I get into my slides is I want to make 4 statements. You heard about utilization and price from Cora. There have been multiple national studies published in top-line journals that have concluded that 25% of healthcare costs are spent on services that are either inappropriate or unnecessary. 25%. And that number has been consistent over a decade. The second point that I want to make is that I don't know what your expectation is about the relationship between cost of care and quality of care, but the correlation between cost and quality is 0. So higher cost doesn't mean better quality. Lower cost doesn't mean worse quality. The relationship is no correlation between the two. The third thing I want to say is that one can improve quality and reduce cost so long as the provider wants to do that. So I spent several years as the EVP of innovation at the Geisinger Health System. It's a very well-known integrated delivery system in Pennsylvania. It's sort of like similar to Cleveland Clinic, Mayo Clinic. Geisinger spun out a company that I became the CEO of, where Geisinger was interested in exporting some of the things that it's done to improve quality and reduce cost to other delivery systems. We worked with 80 delivery systems around the country. I would go and meet with the C-suite at different delivery systems, show them our results in terms of improving quality and reducing cost. And it was, to me, unbelievable, but CEOs and CFOs at some places would say, why in the world would I want to do that? That's a quote. Those places didn't become customers. But it just gives you a sense of the mindset at some places. And the final general statement I'm going to make before I get into my slides, again, echoing what was said in the earlier panel, incentives matter. So in terms of the type of benefit design that Centivo is offering, those types of incentives to individuals matter. And because it matters to the patient, will matter to the provider. Okay, quickly about the physician value study. I don't have to read these to you, but basically what our purpose is to measure quality and efficiency. We don't, at Aisha, make up how quality is measured. Quality is measured using measures that are nationally known, endorsed by NCQA, by NQF. We don't make them up, okay? And they're based on evidence-based guidelines, typically produced by the relevant specialty society. Second, we want to provide our findings to the doc on a doc-specific basis so that the doctor knows where they're performing better and where there's room for improvement. Using the type of machine learning that Aisha has, we can estimate the amount of money that could be saved by moving patients to higher efficiency docs, higher quality docs, or by improving the performance of individual docs. finally, we can identify, or not finally, we can identify the what it is about the patterns of care that differ among the docs who are the better performing docs and the docs who are the poor performing docs. Okay, you've heard we're using the WEO data. I don't need to repeat that. Everybody has to have both medical and pharmacy data because many of the quality measures involve use of particular drugs. As you heard, we base quality on these EVM measures, and I won't go into all the details here. I will say that we require a minimum sample size, number of observations per physician in order to include that physician in the study. And the reason is we want a statistically stable estimate for a doc. And the other thing is that we use confidence intervals around those point estimates as to what percentile they're in to take account of potential variation as a result of sample size. This is just to say that with regard to cost efficiency, we normalize everything to a score of 0. So if you get a score of 0, that's average. If you get a score that's below 0, then your observed costs are less than the predicted cost, and vice versa for if you're greater than 0. And just to reinforce, when we use the word cost, which we often do, it's not really cost. This normalized price, which is not what's paid. And I spent a few years working at Anthem, and I can tell you that the number one thing that we focused on with regard to cost was site of service. That was the easiest, fastest way to reduce cost of care. This is just to reinforce this fact that we had confidence intervals as to our level of confidence, but whether you were in the top quartile, good performance, typical, or below average. And I won't go into the details because of time. The last time we did this study, there was about $1.5 billion in total cost observed. And we estimated that 25.7% of that could be saved either by improving the performance of individual docs or by limiting docs who were participating or getting docs to perform. You know, if you only use docs at the 50 percentile or better, et cetera, et cetera. And we only looked at 8 specialist procedures. So this number is right in line with that 25% estimate that I told you has been published several times about services that are inappropriate or unnecessary. And we'll see what the data show this time. Answer any questions anybody has later if there's time. Thank you.
All right. Thanks, Jeff, for giving me all this time. Is Wayne, do you have a couple things to say?
No, you go. You go.
Okay. All right. Great. As Dave mentioned, Lisa Mrozinski, I'm the head of Total Rewards at Baird. So we are a financial services organization with over 200 locations throughout the U.S. and internationally. And we offer Centivo in kind of every location where it's available for our employees. So we are at the front lines of this. And I just wanted to kind of bring it back around a little bit from an employer context around, you know, the business healthcare group has actually helped us
we're not a huge employer. We are a mid-market employer, and it helps us with, number one, our strategy, as well as all the collaborative efforts that are available as a member of BHCG. So when Cora talks about doing little things, this is a little thing that has actually been a really big impact for us as an organization. So starting somewhere, this is where we started, and it has impacted our organization tremendously. Our prior CEO said that healthcare was a business imperative for us, and this has allowed us to really have an impact on that business imperative, and allowed us to continue to do business in Wisconsin. So we're very appreciative of that. Wayne. Yeah, so I have a couple of questions. So I'm going to start with Wayne, since you haven't had
Okay.
an opportunity to speak yet. But talk to us, you've lived on kind of both the physician leadership side as well as the health plan management side of the room. What do you see in this study that is most compelling from those various different aspects?
Well, so when I was watching this, I was almost thinking about it more from the business strategy side when I was the chief medical officer in health systems. Not, I'm going to speak about that as more than, because, obviously it's a big database. The analytics, are world class. So, when you're first in a physician role, you think, is it good data? Is it believable data? Is it transparent? A third party doing it is quite nice. And will someone talk to me about it? Why it might be a hole in it? How might this affect my physicians? Is there a social determinant that we need to talk about? But when I started thinking about it, I think that someone said it's not going away. And so when I was doing some of this work, for example, in Orlando, we were the first health system set up an accountable care organization. Disney called us and said, you saved 18%. No one else bought it. We did all this work, and it's sort of like you were sort of out in the wilderness. So one of the things with the healthcare group, you've got the employers behind it to say, okay, we will pay for this if you do it. And it's not going away. Then you can plan your strategy around it. And so, I was asked a question about, doesn't this reduce your revenue? Well, not if you're out in front of the primary care model, and not if you're out in front of this. It drives patients to you. So what I was really sitting here thinking is, okay, if someone's going to keep doing this study and I keep getting the results, then I can plan my clinical strategy around it and build around this value-based model. So that's really where my mind went as I listened to this.
Thanks. So for Dana, why aren't other states doing this or other organizations doing this? So there are
Very technical. Okay, now can you hear me? Okay. There are about 25 other states that now have all payer claims databases. A lot of that growth has happened over the last 5 to 7 years. Wisconsin was probably in the first 3 or 4 states, so we've been around a little bit longer. But the biggest difference in our data system is really the way we're governed. Many states are fully governed and supported by their state government, right? And so the APCDs in those states work predominantly, not exclusively, but predominantly on issues that are policy issues that the state wants to better understand. In Wisconsin, we were actually set up as a public-private partnership so that we could serve that function for the state, but also so that the private sector, so all of you in this room, would have the opportunity to access and use the data for a variety of initiatives. So there are more, I guess, other approaches in other states. So the state of Maryland, for example, has done a large consumer campaign called Where the Cost, right? So they calculated the cost of different procedures, and they printed up millions of t-shirts and people wear this, right? To help people to begin to think about what does healthcare actually cost. So there's that. There's a coalition of APCDs that have all done a total cost of care type of activity where the state government actually sets a maximum % increase in healthcare prices per year. And, you know, that's I guess, a little bit more of a top-down approach than this, which is more of a private sector approach. And as Dave mentioned, I think the advantage to this approach is that there are multiple different organizations and individuals involved in it, but it also focuses heavily on the improvement aspect.
One more question, Dr. Earl. We have some new co-sponsors this year of the study. What do you think attracts them to this type of study? Or why would they want to do this?
Yeah, well, I don't know that I can speak for all of the new plans to ventures to be with them. They were attracted for two reasons. First was that the results are provided back to the doc and the health system, and therefore results could promote, drive improvement in things. They also were interested in the fact that there are states that have APCD, and they were attracted to the fact that this could be replicated in other states. And finally, as a requirement for providing their contribution, we had to agree to publish a paper about them, the mainstream journal, about the methodology and results. Welcome to me. I've done a lot of publishing, but those were the things that they called out. And Dave, I don't know all the others.
We do have to gather and the sponsor and participate. Then we have a number
So it's not just publishing the data, it's action
Yeah.
using the data. So really kind of closing the loop or continuous improvement related to healthcare. So I think we're over time already. I'm going to turn it back over to Jeff, unless anyone has a burning question that they really want to ask. Or there's always the opportunity to follow up after the session with any one of our speakers. Thank you. Oh, Pam. You want to repeat the
Sure.
question?
We bring in the commercial data and the Medicare Advantage data from all of the health plans in Wisconsin, except for one. We do bring in self-funded as well, which is contributed predominantly through the Alliance. We would welcome the contribution. Oh, well, we bring in Centivo data now. So we built that data feed in the last 6 months or so. But we would welcome the contribution of other data. The data is available for individual organizations to use. I will say we have different data products. I'd be happy to have a conversation about what might be the best opportunity.
Be able to get the data from your carrier.
Any other questions? If not, I'd like to thank our keynote speakers immensely, and also the two different panels. that we had this afternoon. And where's Ashok? Oh, he's being interviewed. So Ashok, it's kind of funny. Ashok and I use a term called authentic partnership. So think about that, not just a partnership, but an authentic partnership between the Business Healthcare Group and Centivo. And we're going to, trust me, we're going to continue to strive to strengthen that authentic partnership. And for those of you who don't know, we've expanded the geographic footprint of BHCG, and we're continuing to move to the west. And there's one hole we have to fill up in the Fox Valley. And once that's done, we will have built, we won't, Centivo will have built a very powerful network for all of you to be able to use for your employees and dependents seeking services. So with that, and again, I do apologize, we went over, but thank you very much for joining us this afternoon or this morning. Thank you.